article I chose was published on September 19th. It's long-term oxygen therapy for 24 versus 15 hours per day in patients with severe hypoxemia. Just with the oxygen therapy, there's been multiple studies since at least going back into the late 70s, 80s, and that's where most of our Medicare requirements come for oxygen therapy comes from as well. The first study that's the most well-known is the NOT study that was done in 1980. It was done for continuous versus just nocturnal oxygen therapy, and we're going to slightly discuss it. And that's where it came where continuous oxygen therapy has shown benefit. And this was followed up in 2016 and 2020 as well. The 2016 one is the LOT study, which is long-term oxygen therapy in moderate hypoxemia, which didn't show any improvement in terms of continuous oxygen versus difference between continuous and nocturnal. And then the INOX study is basically was shut down earlier because the results were pretty terrible at that time. So the NOT study, it was basically continuous versus nocturnal oxygen therapy in hypoxemic chronic obstructive lung disease, done in 1980. Like we said, it was multi-centered, pretty decent size, 203 patients. It did include patients with severe hypoxemia, which they defined as PaO2 of less than 55 or a PaO2 less than 59, but evidence of heart disease, edema, hematocrit of greater than 55%, and some EKG changes of on EKG changes as well. They define obstructive lung disease as being FEV1 over FVC, like we know about, total lung capacity greater than equal to 80%, and they excluded people that were on oxygen therapy for the previous 2 months. The treatment groups for the study was 12-hour nocturnal oxygen group, or a continuous oxygen therapy, which is defined as anything above 19 hours at a time. And the results, so they characterize the results at both 12-month and 24-month outcomes, and both of those that showed that mortality was 20.6% in the nocturnal oxygen therapy group, 11.9% in the continuous oxygen therapy group, and this was carried over into a 24-month outcome as well, where it was 40.8% in the nocturnal oxygen therapy group and about 22% in the continuous oxygen therapy group. And the relative risk was about 1.94, which was significant, statistically significant at the time. They also did see improvement in hematocrit and some PVR improvement as well in the continuous therapy group compared to just the nocturnal 12-hour oxygen therapy group. And that's where we came with the conclusion that continuous oxygen in severe hypoxemia is probably better than just doing nocturnal oxygen. And this is a survival data, just plotted on a Kaplan-Meier kind of curve. I don't know if it looks pretty hazy up there, but this is the line for the continuous therapy group carried over about 40 months, and this is the continuous therapy group, and this is the nocturnal therapy group. And again, survival benefit. Again, this is from 1980. So the next one was done in 2016, which is basically the randomized trial for long-term oxygen versus long-term oxygen therapy for COPD with moderate desaturations, or the LOT study. It was a much larger study done in 42 centers, about 700 patients, and they were followed up to 6 years. Moderate desaturation as SpO2 of 89 to 93% on room air, and if they're ambulating, the moderate exercise-induced desaturation was characterized as SpO2 greater than 80% for greater than 5 minutes with ambulation, and less than 90% for more than 10 seconds. Patient population that they included was COPD patients with moderate resting desaturations and moderate exercise-induced desaturations. They divided the patients into a 24-hour group of oxygen if their resting SpO2 was 89 to 93%, and oxygen only during sleep and exercise if they had desaturation during exercise. And the ambulatory portion of the oxygen was basically titrated for each person to get their saturations above 90%. All right, and the outcomes that they they included or they looked at was a composite outcome for first hospitalization and death. Secondary outcomes they looked at was incident of COPD exacerbations, patient-reported outcomes, 6-minute walk test as well. Results, just briefly, there was no significant difference between the trial groups in the composite outcomes of death or first hospitalization for either in the continuous versus the nocturnal oxygen group. And then patient with supplemental oxygen reported similar rates of COPD exacerbations, no difference in quality of life, lung function, or 6-minute walk test either. The final outcome was among patients with stable COPD and resting or exercise-induced moderate desaturation, long-term supplemental oxygen did not provide any benefit with respect to time to death or first hospitalization, and did not have any meaningful effect on any of the other measured outcomes that they looked at. Now, coming to this study, which is done this year, basically they looked at long-term oxygen therapy for 24 or 15 hours per day in severe hypoxemia. It was done in Sweden. Primary hypothesis that they had was long-term oxygen therapy used for 24 hours a day as compared with 15 hours a day did not reduce the risk of hospitalization or death from any cause within 1 year. And their inclusion criteria was similar to the NOT study group, where resting PO2 was lower than 55, SpO2 lower than 88 while breathing ambient air, or a PaO2 of less than 60, but with evidence of heart failure or polycythemia. And exclusion criteria, they exclude anyone that was actively smoking. They were assigned randomly into a 1-to-1 ratio to receive either long-term oxygen therapy for 24 hours a day, or receive O2 therapy nocturnally for 15 hours a day. And the outcomes that they measured was hospitalization, death from any cause within 1 year. However, this was addended during the trial because they didn't have significant number of people, so they changed it from death to both death and hospitalization as a primary outcome to increase the power of the study. Secondary outcomes, they looked at hospitalization and death at 3 months and 12 months from COPD, from respiratory disease and or cardiac disease, and all outcome. That's what their secondary outcomes was. They also looked at patient reported outcomes as well, and the compliance of the oxygen therapy and how much they were wearing. So going back to the study population, it was age was around 75 years of age. 40 to 50%, 40 to 45% were males, the rest were females. Most of them were ex-smokers. Most of the patients were COPD, but they did include fibrosis, pulmonary fibrosis patients with severe hypoxemia needing oxygen therapy in the group as well. In their results, though, they saw a similar rate of primary events, which was death and hospitalization from respiratory issues for both the 24-hour group and the 15-hour group. Again, over here, if you see no significant difference between the 24-hour group and 15-hour group, either hospitalization or death, which was the primary outcome, then the subgroup of either hospitalization or death. Over here, they did do subgroup analyses based on PaO2s of less than 55, whether they had a diagnosis of COPD, because they did include fibrotic pulmonary fibrosis patients as well, and all that. Again, they did not see any difference between 24-hour or 15-hour oxygen therapy that was significant in this study. These are more for the secondary outcomes. Again, nothing was significant. They looked at CAT score. They looked at again patient-reported outcomes. Didn't really see any difference in between 24-hour group in terms of quality of life improvement or CAT score improvement or anything of that sort. Again, it was relatively decent sized study, registry based. There was good follow-up of these patients, which does count to the strengths of the study. However, I had an issue with the generalizability of this study, especially since it was based in Sweden, and I thought they were all Swedish citizens. But I guess we'll probably have to look more into the demographic makeup of these of the patients. So they screened everyone that was on oxygen therapy. There was a high screening failure rate, meaning I think they counted, if I'm not mistaken, 16,000 patients initially, and they included only 220 224 or 240 patients in the final analysis. So that contributes to selection bias a little bit as well. This is the conclusion from NEJM, very aptly put in a picture. According to them, among patients with severe hypoxemia, long-term oxygen therapy used for 24 hours per day, compared with 15 hours per day, did not reduce the risk of hospitalization or death within 1 year. Does that mean we change practice? Probably, I wouldn't. It's one study with 200 some patients.